Support for Caring Hearts is provided by the Wright Center for Community Health. VIA Public Media, in association with the Wright Center for Community Health, presents Caring Hearts.
Good evening and welcome. I'm Dr. Clement Shermer, Director of the Geisinger Stroke Centers. I'm so pleased and privileged to host the third annual Caring Hearts panel discussion and dinner. Before we begin, I'd like to introduce you to my fellow panelists. Here to my right, Dr. Linda Thomas-Hemack is the CEO of the Wright Center for Community Health and President of the Wright Center for Graduate Medical Education. She's board certified in pediatrics, internal medicine, and addiction medicine, and practices in her hometown as a primary care physician at the Wright Center for Community Health. Again, to her right, Dr. Leah Van Cook is an accomplished cardiovascular surgeon who has been practicing in Northeast Pennsylvania for over 30 years. To date, Dr. Cook has completed over 20,000 surgeries and touched tens of thousands of lives. In addition to his practice, Dr. Cook is actively involved in his field and the advancement of his field and the evolution of healthcare delivery. Dr. Cook formed the Million Hearts Initiative, which was the basis of which we started this dinner a couple of years back. Again, to his right, Dr. Michael Volk has been the medical director of the Allied Services Institute and Rehabilitation Hospital since 2004, and he's the medical director of the Spinal Cord Injury Unit at Allied Services Rehabilitation Hospital since 1994. Dr. Volk is also the medical director of the Stroke Rehabilitation Unit and the Outpatient Services at Allied Services Institute of Rehabilitation. Here to my left, Dr. Greg Wiener is a practicing vascular and endovascular neurosurgeon at Geisinger, Wyoming Valley Medical Center. His clinical interests include cerebrovascular and endovascular neurosurgery, microvascular decompression for trigeminal neuralgia and hemifacial spasm, and the surgical management through minimally invasive approaches for all neurosurgical diseases, including spine. To his left, Dr. Alexandros Maraldi is a practicing vascular and endovascular surgeon at Geisinger Community Medical Center. He's board certified and fellowship trained, and his clinical interests include carotid disease, aortic aneurysms, peripheral artery disease, mesenteric artery access, and dialysis access. To his left, Dr. Azal Roy is a practicing neurologist at Geisinger Community Medical Center. He's board certified in neurology and fellowship trained in clinical neurophysiology. We're all invested stakeholders here, and thank you all for coming. In health, and we're all individuals, we know individuals, we all have family members, and we have a community. Tonight we're going to focus on the important broad topic of prevention of neurological diseases, interventions, coordination of care, and the undeniable value of patients, family, and community engagement in health. Neurological conditions have the potential to affect every single one of us, and through information, community support, and knowing about our options and resources, we can better understand the spectrum of neurological conditions and how to be empowered to manage and hopefully prevent them. Let's perhaps start with Dr. Van Cook. As we begin our conversation, can you share with us the risk factor and relationship between stroke and heart disease and how the healthcare industry around this concept has changed over the years?
So I've been in practice here for almost 39 years. I trained in a center that emphasized vascular disease, heart and vascular disease in particular. So I've had an extensive experience doing heart surgery, but also vascular surgery. You know, the two are intertwined, at least as far as atherosclerosis is concerned. Atherosclerosis is a disease of blood vessels that affects blood vessels all over the body, in particular the heart and the brain. They constitute the number one reason we all die in this part of the world. So it behooves us to do whatever we can to live long, slow, qualitative lives, right? Everybody's heard me say this before. In fact, how many of you were here 2 years ago when we had a panel discussion? 2017, when we first started this in this center. Well, a few people anyway, that's good. So even though carotid occlusive disease and coronary artery occlusive disease are caused by atherosclerosis, we now have ways to treat them better. It turns out that in the mid-19th century, this was first described, but it took some advancements such as pathologic examination, then arteriography, and ultimately ultrasonography with sonar detection, and even modern techniques such as CAT scan angiography and MRI angiograms to make this an everyday event in my office anyway. And now we have more options to deal with patients before they've had a stroke. And the name of the game, of course, is prevention of stroke. It's a little late. The horse is out of the barn once a stroke has occurred. So our goals here are to prevent this kind of a catastrophic event from occurring. I'm a little bit old school. I trained back in the 70s and 80s with Dr. DeBakey, and who assembled a large team of cardiovascular surgeons in Houston, Texas. They became a mecca for doing cardiac and vascular surgery on a daily basis. And so even though I'm not one of the younger guys, I'm in fact one of the older guys. I may not look that old, but I am. Still, I'm still going. So what do I do every day? I see people who are referred to me because it appears that they do have significant cerebrovascular and cardiac problems, of course. So these two are intertwined. And when I see a patient who has carotid occlusive disease, I want a comprehensive history and physical examination and some basic testing to know not only whether I think they really do have something wrong with the extracranial carotid arteries or other parts of the cerebrovascular circulation, but whether they have heart disease as well. And the reciprocal is true too. If I see patients with heart disease, we also want to know what their cerebrovascular circulation is like. So that's an integral part of evaluating anybody who might have these problems. I'm going to probably speak a little bit about the old world technique, or the conventional technique, not old world. I shouldn't say that because carotid surgery has only been around since the 50s and 60s. In fact, Dr. Michael DeBakey probably is credited with doing the first successful carotid endarterectomy in the United States in 1953, although he didn't publish his results until 6 years later. So Mr. Eastcott and Mr. Robb in England, who did an operation a little bit later, published their report a year later, and they're given credit too for doing the first successful surgical intervention on someone who had severe carotid disease in the neck. My technique for evaluating patients and operating on them stems from my basic experience, but modified by modern techniques of ultrasonography and angiography. When I was in Houston, we used to inject the subclavian arteries, which seems crazy nowadays to inject contrast or dye under pressure, retrograde up the subclavian arteries to image the carotid arteries. We, of course, thankfully don't do that anymore. Now we evaluate patients with a ultrasound probe, and maybe not get an arteriogram done with CAT scanning technique as well. The reasons to operate on somebody, you may know this too, are either that they're having symptoms referable to that particular carotid artery, or often is the case, even though asymptomatic, they have progressive disease with blockages that may turn out to be severe. And by that I mean 75, 80, 85, 90, 95%. Or it's not uncommon now for me to be referred a patient who has a so-called 80 to 99% severe blockage in the carotid artery. If that person is otherwise healthy, active, maybe it's in their best interest, and we'll talk about this, I'm sure, in order to prevent a catastrophic stroke-like event in the future, to operate on the carotid artery. So what do? I do what's called a carotid endarterectomy. Others, Dr. Smaraldi will tell you probably about stenting, which can be done in certain instances too. But I'm a so-called open surgeon. I spend my day in the operating room cutting people open, sadly, but that's what I do. So for me, a carotid endarterectomy is a 3-centimeter incision on the side of the neck with the patient asleep. I train to do it both asleep and awake, and let me tell you, if it's me, I want to be done asleep. You know the definition of a major operation for that matter too, right? Any operation that's done on you or me or our kin is a major operation. So I want to be asleep for a major operation. So I do my patients asleep. I use a minimalistic approach. I don't do a lot of dissection. I go straight to the carotid artery. I give heparin and clamp it, and I do a fancy roto-rooter operation. It's basically that. Now, yes, it's refined, and there's skill involved, and there's judgment involved, and certain things that need to be done, shunting, no shunting, all kinds of measurements that can be done. But for me, having done thousands of these over 39 years, I choose the simple, quick, easy way, so to speak, the technique that Dr. DeBakey and Dr. Cooley espoused in Houston. I usually patch arteries, not that that's of significance to you, But at the end of the operation, I like to awaken my patients and make sure they're neurologically intact. Then I keep them in the hospital overnight, send them home the next day, as long as blood pressure has been controlled. And for 4 days, I ask them to take it easy. After that, we resume normal activities. So the treatment for this is a preventative one, in my view, to try to prevent a stroke. It doesn't make anybody any smarter or younger or better looking. It's simply to prevent catastrophic stroke. When that works, it's great. There are risks involved, and it's said that you should not have a carotid endarterectomy unless you go to a surgeon who does it routinely and a hospital that does it routinely, and where the combined risk of death and stroke is less than 3%. Knock on wood, I've never had a stroke in any of my patients, death in any of my patients. I've had one stroke in thousands of people. A big fellow who had a delayed stroke later on. He was incredibly hypertensive. So in my experience, it's a low-risk operation, but there's a lot of judgment involved as to when to do it, how to do it, and how to monitor people. And there have been a lot of refinements that I'm sure we're going to touch on how to monitor people in a modern-day hospital, and even once they go home, to make sure that blood pressure and other hemodynamic variables are controlled. So I don't want to speak too long or take everybody else's thunder. So I'll stop there and wait for questions later on. Anyway, thank you, by the way, for inviting me back. I was here 2 years ago. In fact, I just showed Dr. Thomas the email I got from Betsy McGrath in 2017 when this all started. And I'm going to keep one from today in my other pocket in case this happens again. Thank you.
So thank you for this, for these introductory, thoughts. Maybe moving a little bit more up to the brain, Dr. Wiener, you can talk to us a little bit about when that stroke happens, what is new in that area, and how does that then maybe relate to the prevention part again that people are interested in, I guess, when they come to us in both ways.
Thank you very much. I want to piggyback a little bit on the preventative aspect of things. Actually, the preventative measures don't really occur in my office so much as ultrasonography. It's really in the family practice office, the internal medicine offices, the pediatric offices for some patients. It's really the residents that are being trained through the Wright Institute that are really doing the preventative care, because stopping diabetes, having control over hypertension, smoking, obesity, atrial fibrillation, those are really the preventative measures for most of strokes. And I actually just I Googled the cost to our society from stroke each year, and it's $34 billion versus healthcare costs as well as lost wages. So you can just Google on your phone, the first thing that comes up is $34 billion. It's actually a staggering number. So prevention is really in not the surgeon's office so much, but really in the primary care office, and that's why this organization is so essential to our community. As far as moving up in the brain, things have changed a lot in acute stroke intervention, not so much as preventative stroke care. Not all patients that come with stroke are caused by stenosis in the carotid artery. It could be from atrial fibrillation, hypercoagulable state. Even I had a pediatric patient that had a congenital heart disease that had an acute occlusion of one of their brain vessels. And really in the late 90s, everything changed with taking care of acute stroke patients. That was with the randomized trial looking at the benefit of a clot busting agent, or a TPA, that people know about. You come in with a new stroke, within 4.5 hours now, you can get this clot busting medication. And everything was really stagnant for about a decade and a half until 2013, where unfortunately we had a lot of trials that randomized trials that showed that going up and taking out a blood clot was actually not beneficial. And that was really devastating to a lot of us that felt that going up through an artery and pulling out a blockage in the brain and reperfusing that brain would have helped. It makes sense. Taking a blockage, opening it up would help. And unfortunately in 2013, it showed that because the trials weren't run very well, showed to be not beneficial for patients. But in 2015, we had 6 positive randomized trials that showed benefit to doing what's called a mechanical thrombectomy, where a patient who comes in now within 24 hours of an acute stroke with a small amount of stroke, I can go up through the artery in the thigh, through the artery in the wrist, or even directly into the carotid artery with a combination of catheters, wires, and stents on sticks, and actually pull the clot out to allow reperfusion of the brain. And I've seen patients my youngest patient I treated was actually 9 years old who had a congenital heart disease I did at Children's Hospital, and the oldest was over 100. And I've seen patients completely recover after these operations. Some don't, but it has changed drastically just in the last 4 years. And the amount of technology that we have is just growing exponentially each year. So.
Okay, great. So moving, over maybe again to the prevention side and, so like the acute side or around this, Dr. Roy, where do you see stroke care going? Like, what is sort of like new in that area?
Yeah, so stroke is a condition that is very common, and that happens about 795,000 people every year in US, and among those 680,000 would be new stroke, and 110 is like a recurrent stroke. And stroke, Dr. Weiner said that it forms a big burden to our society, including like a lot of money and like a lot of disability and death. And so before going to your answer, let me tell what are the types of strokes and how it happens, then I can go there to make people aware. So stroke is a condition in that poor blood supply to the brain causes brain cell death, and it's important because time, and there are main two types of stroke. One is hemorrhagic stroke and another is ischemic stroke. So out of 100, 87% would be ischemic stroke. That's more common in US. And 13% is hemorrhagic stroke. Hemorrhage means the hemorrhage can happen inside the brain, my brain tissue inside. That is the intraparenchymal hemorrhage, and it can happen around the brain as well. So to get hemorrhagic stroke, most common cause would be uncontrolled blood pressure or too high blood pressure. And that is very controllable. Like if you keep close follow-up with your primary care doctor. And for my patient, I ask them to keep a blood pressure monitor at home to measure at least 3 times a week in morning and put in the chart in a notebook, and that you can see the trend. And number 2 would be trauma, and that happens anytime. And number 3 would be having tumor inside the brain or abnormal blood vessel, like outpouching of the blood vessel that's known as aneurysm. And the bleeding can happen around the brain as well. That is known as subarachnoid hemorrhage. That's happened 3%, and most of the time, trauma or outpouching of the blood vessel cause the hemorrhage. And we ask help from our colleague, neurosurgeon, for that. So big chunk of the stroke is ischemic stroke, and ischemic stroke happens, most common cause would be that known as cryptogenic stroke, like 30% out of 100. We don't know the cause, but we have to chase, we have to find the cause because we need to prevent the next one. And the second one gonna be like small stroke that happens inside the brain, that known as lacunar stroke, that due to uncontrolled blood pressure, long term, along with smoking, alcohol, and aging, that causes a small area of blood vessel to get clogged, and that forms a small stroke. And they do pretty well in recovery. And next one gonna be 2 big chunk, like 20% and 20%. One is known as cardioembolic stroke. It happens due to, most common is irregular heart rate. That medical term is atrial fibrillation. And it can happen as well who has MI, like heart attack, and if the heart is not moving well, it can form a clot, and a small fragment can go to brain and clog the brain artery and can cause stroke. And other cause would be having clog that in the neck due to high cholesterol along with diabetes and smoking, and that can form a clot there, and that can go to the brain and block the brain artery and can cause stroke. And most important thing for the stroke to know the symptom. And anybody has a heart pain or heart condition, they comes to the hospital. But for the stroke, they don't. And stroke symptom is, we say fast, face droop, arm weakness or numbness, and speech, slurred speech or word finding difficulty or cannot talk. And time is the brain. And time means you need to call 911. And that's one of the things. I saw a lot of catastrophe. Patient tried driving to the hospital, or their loved one tries driving, and I treat 2 patients because they see their loved ones are collapsing, and we need to treat both of them. So call 911, and they know what to do, and your treatment starts from your home. When they see the patient and they think it's stroke, they call us, and we are ready in the hospital. As a neurologist, our lab, our imaging, our emergency doctor, and the patient has like a change in mental status or like seizure on the way, they know how to treat them. And they are the first people to come to the hospital. Then when they come to the hospital, we go and see the patient, and we evaluate them, and patient gets quick CAT scan to find if there is bleed or not. If no bleed, we start the treatment. And the first treatment is clot buster. If there is no bleed any part of the body or no recent surgery, and if there are not any oral blood thinning agent, then we can treat them with clot buster, that known as TPA or alteplase. And that's the standard of treatment. And time is brain. Every minute, 1.9 million neurons are dying. So we give this medication ASAP basis, and you need to come in hospital within 4.5 hours. We can give this medication up to 4.5 hours time. And not only that, if depending on like how bad is the stroke, we do a stroke scale. We do a CT angiogram, like look at the blood vessel, and we ask our colleagues help to get the intervention. They can go there inside the blood vessel and suck the clot off. And that is the starting of the treatment. And stroke itself doesn't kill, it can kill patient, but most of the patient dies from the complication of the stroke. When they're in hospital, they can get bed sore, they get pneumonia due to like trouble swallowing, they can get bleed inside the stomach, they get a clot in the leg that can go to the lung. These are the stuff, and we have, if they have trouble swallowing, we have a speech therapist, they get treatment from them. If they cannot walk, we have a physical therapist, they help them with the walking. If they cannot feed themselves or like cannot brush, we have occupational therapist, and most of the stroke patients get depressed. And we have psychiatrists as well. We work as a team there. And for the prevention, like stroke, when a patient gets stroke, horses out of the barn, most of the time, we can do a lot of stuff, but most of the time, brain cell is dead. We try to save as much as we can. So to prevent the stroke, we treat making platelet less sticky. Platelet is a small blood cell in the body that helps you to stop bleeding. And there are 3 medications available. One is aspirin, that very old one, and next one gonna be clopidogrel or Plavix, and third one is Agrenox. And we start depending on what are the factors are there, and we also keep their blood pressure under well control. And third medication would be cholesterol. Every stroke patient, if it's a clot there in the brain, or like it's a ischemic stroke, they should be on a statin. These 3 medication prevents a stroke to come. And with the physical therapy and rehabilitation, they do pretty well. And how well they're gonna do, it depends on like area of the brain where the stroke and how big is the stroke and how quick patient comes to the emergency. So the new treatment would be here, that is the breakthrough that came recently, like the Geisinger that provides intervention that is going through the groin, and it could be done, we used to say it could be done within 6 hours of a stroke starting, but now we extended the window, it could be done within 24 hours. So that's a big window. So somebody found on the floor or your loved one, next morning you are calling and they are still in the bed, you go there, you should come to the emergency, you shouldn't wait. You don't think like, oh, I don't know when it start. Still, we have some way to help them. So that's kind of new, and that helps with the recovery.
Yeah, thank you. This is great. So I think that that's a key takeaway, right? That, we can now do this up to 24 hours out rather than having these really short time windows only.
Yes.
But it also sounds really complicated. And maybe Dr. Smeraldi, you can help us out a little bit. Working as a specialist, but with other people, how do you navigate like this collaborative network that we're trying to prepare and have available for our patients?
Again, thank you for having me here, Dr. Thomas, and being part of the panel. I feel a little guilty because I get to, the horse isn't out of the barn for me. As a vascular surgeon, I try and keep the horse in the barn and to not let it out. Once a patient's identified as a risk for a stroke, whether it's from high-grade carotid disease, like Dr. Von Cook was saying, or there's other risk factors, like Dr. Wiener was saying, that there are diabetes, high blood pressure, or high-grade blockages in the carotid arteries that put people at risk. Our job as the surgeons is to prevent that from happening, and to also identify that that's actually the right place where the stroke is going to happen. Like Dr. Wiener said, there are other things that cause stroke. Dr. Roy, you mentioned other causes, the cardiac reasons, clots in the heart. There are other things that cause stroke. Although the carotid artery is often the culprit, it's not always the culprit. And so working collaboratively with neurologists, with neurosurgeons, with the primary care team, and in the hospital and outside of the hospital, it's really important to clarify and make sure that we're operating on the right people at the right time for the right reason. And then the treatment that we have to offer them is based on all that information that's put together from collaboration. And we can offer them traditional surgery, like Dr. Von Cook was talking about, which is very time-tested and very secure. There are other newer procedures that involve putting a stent inside of the artery, which doesn't remove the plaque. It doesn't prevent the plaque from traveling in that we don't take it out with traditional surgery, but by placing a stent, which is a cylindrical tube inside of the artery, we actually still prevent the plaque from going to the brain by trapping it. And Dr. Wiener obviously can talk more about different ways that we do that, but the right procedure then for the right person is important, and to keep our stroke rate low for the procedure so that we're able to keep our patients safe, in general.
Great. So, that sounds like a very promising way of going about things, but unfortunately, it doesn't always work out, right? So when it then fails, I think that's where you come into play, Dr. Volk. We do eventually have to send our patients to rehab, and, I think there's some new things there too, and the post-acute stage of stroke care is really, really important, because I think, we can, as it was alluded to, we can do a lot of things in the hospital, but that's not where you recover, right?
Correct. Again, as the other panelists said, I do want to thank the Wright Center for asking me to be on the panel and to have such a program to educate the community. I like to think of a mnemonic when I'm thinking about strokes. The mnemonic I use is PRICE, which is what price would you pay to prevent having a stroke, or the consequences of stroke. And I think of P, first of all, as prevention. We all sort of mentioned it already. The things that you can do, you can't do anything about genetics. You're born with, what potential risk factors you may have, but there are things that you can do. No smoking, watch your diet, things that have already been mentioned about watching control of your blood pressure, control of your diabetes, those type of things. The R then is recognition, as Dr. Roy said, recognizing as quickly as possible if you are having the signs or symptoms related to stroke, whether it's some slurring of your speech, some weakness of your arm, tingling, those type of things. The mnemonic that the American Heart Association has is FAST. And T is critical, that time to call 911 and get to care. So the I then is intervention. And it's what all you folks have already been talking about, what your skills are, some of the new technologies available to intervene, whether it be a clot buster, whether it be a surgical procedure, in order to try and prevent the stroke from either occurring or from being devastating. And in some cases, the C then is the cure. Many times the intervention that you folks provide actually cure the individual from having the stroke. Unfortunately, people who have stroke, there's a 50% chance of having a second stroke compared to someone who's never had a stroke. And then the E is to enlist. And when I say enlist, that means to enlist rehab. Because there are individuals who, though intervention will occur, they don't get a cure, and they're not quote-unquote normal again. And you want to be able to walk, you want to be able to feed yourself, you want to be able to do as many of the things that you could do that you did before. It was mentioned before that when a stroke occurs, that the brain, that tissue, that area of the brain that's been affected is dead. And decades ago, we thought that that was it. The dead tissue is dead. There's nothing that can be done. There's a concept called neuroplasticity. There is a window of opportunity where that tissue may not quite be dead, or there are other things that can be done. I always talk about the three areas. There's the area of the brain that's been affected. There's the area immediately around the area that's been affected. And then there's the area of the brain that's distant to the area that's been affected. And that period of neuroplasticity is that period of time where we have a chance to change some of those areas. We might be able to improve the area that's been affected. We certainly can improve the area around the area that's been affected. And then there are areas away from the area that's been affected that have been quiet. They've been shut down. They don't work. And until the area of the brain that's been affected, we try to wake up those silent parts of the brain to take over some of the function where that dead tissue used to work. So what is that period of neuroplasticity? Our greatest opportunity to have the greatest amount of change is during that first 3 to 4 months. That's where neuroplasticity is, if you will, the most plastic, the most pliable, where we can have the most change. But even if you don't affect change during that period of time, individuals can continue to improve years, decades after a stroke has occurred, depending on the intervention that you use. That first 3 to 4 months, though, for me, is what's the most critical. And what are the things that you can do, what can be done during that period of time to get stroke recovery? It's not just about physical therapy, occupational therapy, speech therapy, those type of interventions where you're doing some range of motion, you're doing some strengthening, you're trying to get them to walk, you're trying to get them to swallow. But there are things that we can do to the brain during that neuroplasticity period that have an effect on it. The first is the medical side. What can the physician do? Well, there are medications that can be used that can help enhance that neuroplasticity. There are things such as even Ritalin, which is used in kids with ADD, that is used. We talked about the psychologic component. Well, there's an organic depression and a reactive depression that occur, and some of those chemicals that are used as antidepressants actually can also enhance the neuroplasticity. So there's a number of medications that can be used that would be beneficial, as well as the medications that are needed to continue to control the heart rate, to control the blood pressure, to control the diabetes, all those type of things. The nursing care that's involved initially after a stroke is critical. Watching for the skin, taking care of the bowel and bladder concerns, and basically trying to continue the efforts on a 24-hour period of getting the individual to do the things they're being taught in therapy. Besides the things in therapy that I already mentioned, the things that you already think of, there are things to enhance that recovery. We use functional electric stimulation, where we're teaching the brain what it's like to stimulate the hand to move, even though the signal's not coming from the brain. We're signaling it the other way and hoping that the brain recognizes that through a biofeedback, if you will. We use body weight support training. We use robotic therapy. We even use Wii and virtual reality. Anything that will help with those visual spatial aspects of care to get the brain to recognize what it's like to try and do those functions again. Counseling is important as well. Social services, social work is so important with regards to being able to make sure the patient is able to continue their services. Can they get insurance coverage? What are the types of things that are necessary? We know for a fact from the medical literature that there is this period of neuroplasticity, that it is those 3 months. We also know that if you are good at, first of all, we always say, like the Wizard of Oz, there's no place like home. We always want patients to go home. And if they do well enough in the acute care hospital that they can go home, they can get their rehabilitation then as an outpatient or at home. But for those who are not fortunate enough to be able to be well enough to go home right away, they need a stepping stone. They need to go someplace first where they can get the intense rehabilitation necessary to then move to the next step, which hopefully would be home health or an outpatient type of program. And there are no other facilities other than an inpatient stroke unit in an inpatient rehab hospital that can provide all of those type of services more than, say, a skilled nursing facility. Sometimes skilled nursing facilities are necessary because individuals need a slower pace in order to try and improve. But to have all the technologies and to really be able to take the opportunity of that 3-month, 4-month window of time of that neuroplasticity, we always say inpatient rehabilitation is the best place to be.
Great. I mean, this is fascinating. So are you saying that virtual reality is, no pun intended, now actually a reality in the way you
we do
care for
virtual
patients?
reality. We have a green room. So everything around the patient is actually absent on the screen, and the patient sees themselves doing whatever the task is that we have them trying to do. Virtual reality has been very, very beneficial in certain patients.
Great. So maybe circling back around, so Dr. Thomas, where do you see this going in terms of like reaching out to patients, empowering patients to like really also take ownership in their own care, right? I mean, this is what we're trying to like convey to people, how to do this.
So the role of primary care is changing. And, as we get better and better and the technology changes on your end, we're very joyfully trying to shrink the need for any of your services. So on the primary care side, it's really about prevention, one patient at a time, optimizing people's health. I think the traditional risk factors of blood pressure and smoking and cholesterol. I think that there's a very deep and evolving primary care interest right now in what we consider to be the major American risk factor for stroke, which is stress and stress management, and helping people more in a recovery mindset of how you manage and process the daily complexities of your life, but also the moments where devastating things happen to your closest kin, right? So we're very into stress management. We're much more active in the behavioral health world and screening for mental resiliency and coping skills and depression and anxiety, and trying to help people better navigate the systems and support systems that they need to better manage that gigantic risk factor. The other part of primary care that's really interesting is not at the level of the individual patients, but at the level of public education campaigns. There is nothing more devastating than a patient who stayed home with their heart attack, okay, or home with their stroke, that missed that window. And so that chiasmic gap between what we know in science and all the technology that we have and the disparities to really engage patients and families in immediate recognition and tapping the resources that can have permanent, just incredible indications for their outcomes is really important. So the public education campaign is a big space for primary care, treating individuals one-on-one, helping them with coping and resiliency skills that help them to better manage their chronic disease and their chronic risk factors is enormous. I think the other space where primary care is really rallying is kind of the space that we stepped out of when we stopped going to hospitals. And when patients sometimes lose their personal story and the awareness that the system has of their story, how can we use technology to kind of now bring primary care back into the action of when it's happening? Because far from the technology and the technological interventions, we bring connection to their story, awareness of their wishes, awareness of their next of kin, and an advocacy and a longitudinal relationship that frankly is sometimes missing in hospital systems. So using technology to kind of reconnect with patients, reconnect with hospital teams, and to bring what I consider to be one of my greatest roles as a primary care doctor, which is connecting dots, making sure everybody's chatting, making sure everybody's talking, and making sure that the loudest voice is the patient's and the families, so that we're honoring what they want to happen, because many of the times, if patients have a choice, right, 99% of them, they want to go home, right? And you enable them to go home, right? And stroke it's tragic, right? It is from a primary care standpoint, we are devastated when that happens to a patient. We want to be there, we want to advocate for them, we want people to know their story. And so that's probably from a primary care standpoint, we want all the people that are involved in the crisis to all be communicating, and we want them to know the patient's name, and we want that patient to be somebody where if they recover, the people that took care of them in the hospital will recognize them in the mall and take joy in their recovery, and the endless gratitude of their families. So now I'll summarize with just, what's the one take-home point? I think stroke is tragic. Time is brain. You shouldn't feel foolish. We would much rather see you in the healthcare delivery system and reassure you that maybe it was an anxiety attack or maybe something went on. That's not stroke. We would rather do the reassurance and send you on your merry way than have a devastating outcome of a patient who stays home with a stroke, just like you stay home with your chest pain. So my takeaway is recognize it and come immediately for help. Call 911. If you are not sure, all you need is a suspicion, call 911. So just take home points from each of the panelists. Dr. Cook?
I see a young man in the audience. It happens to be Dr. Smeraldi's son. He's in the 5th grade. And I think that's the time we start telling people this, individuals this. You need to grow up knowing that these things are going to happen to you too. It happens to all of us, right? No one is immune from illness, from aging, which is part of the problem. So start at a young age to take care of yourself. Learn what to do, what not to do, how to control risk factors, as you were saying. Don't smoke. Watch blood pressure. Watch your diet. Be active. Don't be sedentary. Be active. We live in an age of information technology. Still, be physically active. Do the right things to protect yourself. And that needs to be communicated to the young so that they are planning on this in advance. Maybe that'll change the way healthcare is delivered in this country. I don't know.
I agree. Dr. Wolk?
My take-home point would probably be that you always have a choice. You have a choice early on, as Dr. Von Cook has said, about choosing whether you smoke or don't. What do you choose with your diet? Choosing your doctor, and when an event occurs, choosing again your healthcare system. Where are you going to go if you're going to have a stroke? You want to go to a primary stroke center. Choice of what type of procedure you want to have. Choice afterwards with regards to where do you want to go for your rehabilitation. Choice of where do I want to go as far as I want to go home. I mean, everybody usually is going to have that choice. So again, I think all through these stages, all through your life, you always have choices and try to choose the best.
Dr. Roy?
So I told call 911, and all of you guys and your loved ones should know first. And another thing is prevention is better than cure. And we know all the stroke risk factors, that one group of risk factors that we cannot modify, like our age, and sometimes male get more stroke than female, and history of prior stroke, or family history of stroke, or family history of heart disease. This group of condition we cannot change, but a lot of stuff we can change, like our blood pressure, we can control well. Number 2 would be our smoking. We can stop, and we can get seek help from our primary care doctor or counselor, along with nicotine patch or whatever treatment your primary care provides. You can stop smoking. For diabetes, your hemoglobin A1C should be well controlled, and you should closely follow up with your primary care doctor. Then your heart condition, you need to closely follow up with your doctors. And next thing would be exercise. That's pretty important for your life. And you should do at least 30 minutes of exercise, at least 5 days a week, along with food habit. It's shown all the data that Mediterranean food that includes a lot of fruits and vegetables, along with low fat dairy product and less red meat and fatty stuff, that helps. And next one gonna be coming to your hospital ASAP. There's the thing, if you have a symptom.
Yes. Dr. Smeraldi?
Take home is health maintenance. I tell all my patients, most of them who do have cars, that they don't wait until the wheels fall off to take the car in for a checkup. Make sure you take yourselves in for a checkup regularly. Your primary care doctor is really the person who's going to create that relationship that will allow you to stay healthy. whether it's monitoring your risk factors or helping you pick the right surgeon or the right procedure or the right kind of recovery for whatever goes on in your life. That's the key there, and maintaining that relationship is so important.
Dr. Weiner?
Yeah, so it's actually my take home is not going to be for patients or potential patients, but more for the practitioners. There are 6 people up here, 7 people up here with 6 different subspecialties, and it's all about teamwork with the same goal. So it shouldn't just be practitioners or surgeons and then the primary care folks. It should be a team effort. And the take home is we shouldn't just meet you when the bad event is happening. We should in our community always be involved, like in these events, and have that go forward. So teamwork is essential. So.
Thank you very much. Dr. Shermer?
Yeah, so I thank you for all these points, and I think it's fascinating to me because I think everyone really crystallizes what needs to be done, and I want to maybe turn this around a little bit, and I guess throw this back in everyone's face and say like, okay, so but where are we failing, and how do we need to maybe adjust some of these expectations that we just verbalized for this community? And how can we do better? Because I think we all realize what needs to be done, and I think there's guidelines, there's best practices. We all have a pretty similar idea about what should be done, what's the ideal state. But clearly, we also realize that that's not happening. Especially this area is not necessarily considered part of what's called the stroke belt, but we're also not one of the more healthy parts of the country. So I think there's probably lots of opportunity and gaps for improvement. So I want to maybe go back around now and see like what is the specific one thing that we should maybe tackle in this community, I guess. Or we could start
So
here.
what I found, like when I started my practice in this area about 5 years ago, moved from Danville, I used to see a lot of young patients having a stroke. 2 things can cause stroke. The bleeding stroke, crystal meth that shoots the blood pressure can cause bleed, and a lot of cocaine used to do a lot of stroke. But I don't know what's going on in this community. Might be your narcotic or addiction clinic that's helping. And last 1 year, I didn't see a single stroke from coke or crystal meth. So there's something happening good in this community.
That's very good.
So it's interesting. If you asked me several years ago, I would tell you it's education. We need to be able to educate. A program like this, I know that part of our rehabilitation program, I always like to think about prehab, not rehab. What can we do ahead of time when we do stroke support groups, get out to the schools? You're always out there, American Heart Association, American Stroke Association, trying to do everything they can to educate. But as I've grown older, wiser, mature, I don't know what the word is, but it's access to care. I think that's the area where we may be failing in. If you ask about where can we make an improvement, we have many patients, many people in our community that don't have access to care. And I think that's the area that we need to try and improve upon.
Dr. Wilcock, do you see that the same way, or?
Well, yes and no. There's nothing you can do about the other fella. The only person in life you can control is yourself. So everybody needs to do the right thing for himself or herself. How do you know what to do? You have to be educated, as you point out, to do that. I think we need to start at an earlier age to realize that we're going to grow up and pay taxes. We need to learn about sex education in the real way and not at the school bus stop. And we have to learn we're all going to get old. We're all going to get sick. Something is going to happen. Plan for the future. Be smart about it, and then do the right thing. And now, forums like this provide information to the populace out there indicating that there are options, as we're all saying. If something does go wrong, God forbid, you have a way to deal with it. 911, get thee to a hospital, and go from there.
But maybe I can hold back against this a little bit. So I think that's making some assumptions about how mature people are about taking care of themselves, right? And we know that that's not necessarily working so well. And are we maybe relying a little bit too much on 911 to take care of all these things? I mean, not necessarily limited to stroke now, but just all sorts of healthcare problems?
Maybe, and sadly, maybe we're much like the Romans, the most civilized society at the time who self-destructed. There is a view of the American as the spoiled brat who thinks that everything will come easy, nothing will ever happen to me, and when it does, I'll be taken care of. I think that has to be reversed. I think we have to realize that we're vulnerable. Something is going to happen. So learn and prevent if possible?
I think if I could just make a quick comment, I don't believe any one of us on the stage here has suffered a stroke in their lifetime. And it's very easy, or seems easy, for us to talk to our patients about what they should or shouldn't do and what they need to do, etc. But we were not in their position. One of the things that we provide as well is a peer visitor program, so they get to speak to somebody who's actually been in their shoes. And I think more of that, reaching out where somebody who's actually been in their shoes has been very empowering.
I think that's a great point. How do you communicate to your patients about this? Like when we're talking about sort of like the theoretical consequences of a stroke that you're trying to prevent when they're sitting in your office?
It's incredibly time consuming, and it's one of the challenges that I face as a surgeon, where my time and my interaction with the patient is relatively brief, and my job, I do feel, is partly to educate them as to the risks, not only of how to prevent the stroke, but what are the consequences of not preventing the stroke, and what happens when you let things go amok. And that, I think, takes a lot of time, but it's rewarding. And I think in that, once the patients understand that, and once families understand that, so that it's not just you and one other person in the exam room, but it's you and the patient and family members, I think engaging people at that level really seems to drive the point home a lot better when we talk about the risk factors and the consequences, both ends of it.
Great. Dr. Wiener, how do you discuss risk with a patient in particular? Like, how do you convey like possibilities, options? Like, what have you found beneficial in that regard?
Well, before I get to that, I wanted to kind of say one comment about what we're maybe doing wrong in this area, and I'm probably going to get myself in trouble for this. You know, unfortunately, healthcare is a business these days, and in this area, the Northeast, we have 2 major health systems and probably soon to be 3. And what that means is that the right thing for the patient isn't always done. And so for the emergency room doctor, for the primary care doctor, whatever the business is of the hospital system, you shouldn't be sending a patient 2 hours away to another healthcare system just because you have a relationship with them. The closest hospital is 25 minutes away that can do the best thing and send them there. It's about the patient, not about the dollar sign. So that's all I got to say.
Yeah, I think that's a very good point. So I'll let you off the hook for the other one.
Thanks. Yeah.
So yeah, I think that's a great point, and maybe you can speak to this a little bit as to like a part of an entity that is not entirely part of one of these 2 or 3 larger players in this area. How do you navigate this, both from an institutional perspective, but then also as a personal primary care doctor?
So, we live in northeastern Pennsylvania, and I always tell people we have competing systems. But, if you have a baby, you go to one system. If you bring your newborn home and you get in a car accident, you go to the other system. And at some point, we want them all talking, because the optimum care of stroke is system naive. We just want to get the patient what they need. So part of the reason that the Wright Center maintains its community governance and its community ownership and its independence and kind of its Switzerland position, I suppose, to be friends with everybody, is because we are very committed to the patients and families getting whatever they need, regardless of where that is. And we have friends everywhere because we've been around for 40 years and we've been generating doctors. So a lot of doctors that work in those competing systems are actually our graduates. And, I was really privileged to call one of the CMOs from CHS to ask her to be on this panel, and Mary Sawatsky, she's one of our graduates, and unfortunately she's out of town. But I asked Mary, I said, Mary, in the heat of the moment, in the middle of a stroke, what would you do? And she said, I'd send my patient to the closest stroke center, which is Geisinger, Wyoming Valley. And so at the end of the day, I think it's your relational leadership of connecting us as a community, that, in the middle of a crisis, all the business nonsense goes away, right? We have to do the right thing. And by doing the right thing, we will keep people far away from moral injury, and staying far away from moral injury will lead to joy in practice. And joy is contagious, right? And happiness is contagious. And so, and at the same time, in the routine daily grind, we can all go to our business models, and we have to survive, and we have to have the resources to be able to build the business models. But at the end of the day, it's a very human conversation, and it's a community conversation, which honestly is why we're here. And why my children are in the audience to hear you. Not only Alessandro's. So thank you.
I think that's great. So I think with this conversation that we just had and the discussion around these concepts, maybe we'll do one last round, and I want to really have like a 30-second, one thought takeaway that we want to leave our audience with, to wrap up. So maybe we'll just start, for I don't know, no particular reason, but we'll start maybe on your side with the continuum of care, I guess. What do you want people to know?
So take-home message would be call 911 and come hospital ASAP basis. And there is no alternative of that. If you try yourself or your loved one, you might hurt your loved one. That's the most important thing. And any stroke symptom that I told fast, face, arm, speech, call 911, period. And that's a social awareness we need, because if you have a little bit chest pain, you go in morning 2 o'clock or 3 o'clock to hospital. But if you have tingling, numbness, or face droop, you wait for the next day. And then horses out of the barn.
Great. Dr. Smaraldi?
Yeah, keep the horse in the barn. Make sure that you communicate and talk to your primary care physician. My take-home message is prevention. Make sure that you communicate with your doctors, not only as a professional, but as a friend, so that they can keep you healthy.
Okay. Dr. Wayne?
If you feel that something's not going right in your care, speak up. Don't take everything to heart, and don't keep yourself silent. We'll hear about our personal example here. If something is not going right, sound the alarms. Make sure things are going right direction.
Dr. Francouk?
Ditto. I like what those guys said.
That's a great elevator pitch. All right. Dr. Wolk?
The only thing I'd add, without being repetitive, is that we're all, as part of the medical community, not done. There are still things that we haven't talked about that are still coming. The new technologies that you folks are doing, some of the technologies in rehabilitation we're talking about, there's still other futuristic things that are out there that hopefully will either eradicate strokes from occurring or eradicate the deficits that stroke has. There's brain stimulation that's coming out. There's stem cell trials that are coming out. So there's lots of other things in the future that still may be available down the road that will eradicate the devastation that stroke can have.
Dr. Thomas?
So love and value yourself, love and value your neighbor, and love and value our community.
Great. So my colleagues and I, we would like to thank our audience for being part of this very important discussion. I think this was a great conversation that we had here. And to our viewers at home, thank you for watching, and thank you very much.
Support for Caring Hearts was provided by the Wright Center for Community Health.